Asha ma'am, Dr. Chandramati has logged in, so we have all the
Yes.
chairpersons for the initiative.
A very warm good evening to each and every faculty present here. This is Piyush from Corona Remedies. Welcomes you all to the Searchlight 04 and on hypertensive disorder in pregnancy in association with Hyderabad, Karimnagar, Khammam, Mahbubnagar, Moncherial, Nalgonda, Nizamabad, and Warangal. Again, a very warm welcome to each and everybody present here. Introducing you all with our you all with our program mentor, Dr. Asha Jain ma'am.
Piyush,
Dr. Asha Jain ma'am.
Piyush, listen.
Yes,
First,
ma'am.
let us do the lamp lighting and then you can introduce me.
Sure, ma'am. Sure, ma'am. Actually, I was just going to hand over the session to you and ask you to proceed forward.
Let's have the lamp lighting first.
Sure. I'd like to invite each and everybody to please start the program as per the tradition with the lamp lighting ceremony.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Again, a very warm welcome, everybody. I'd like to introduce you all with our program director for today's webinar, Dr. Asha Jain ma'am. The lady needs no kind of introduction as she has been in the industry since more than 35 years now. She has vast level of experience and knowledge to share with everybody. And if I tell you about the sort of achievement she had, the sort of impact she had in the industry, I'd like to tell you with this that she is the director of SMSA Hospital, Raipur, which is also recognized by Foxy in ultrasound training and colposcopy. She has vast level of academic knowledge. She has areas of interest like saving uterus, fetal medicine, obstetric and gynec, and critical care, prevention, oncology, and colposcopy. She has been medical director. She's medical director, Cancer Prevention and Relief Society, elected member, Chhattisgarh Medical Council, and a lot more. Very, very welcome, ma'am. And I'd like to hand over the session to you.
Thank you. Thank you, Piyush, for that kind introduction. Namaskar from my side to all the dignitaries present here. Because Shanta ma'am is very busy, I would be introducing her first. She's our guest of honor. And may I have her CV, please? Piyush, what is happening?
Dr. Asha?
Yes, ma'am.
Actually, there are some.
I don't think we need to have an CV slide. Can I just, I would like to congratulate you and the whole team for doing this academic program. And yes, rightly put, I think hypertension in pregnancy is definitely one of the most stressful conditions which obstetricians face. And we need to work towards trying to identify these patients at the earliest so that we can reduce the incidence of maternal morbidity and mortality. I think that's so very important that we all work towards this very important medical disorder which is definitely a challenge to all of us. So I wish all the consultants, the juniors, the seniors, and everyone so that we don't miss any case of the faculty and the delegates also. Thank you.
Thank you, Shanta ma'am. Thanks for making that effort to, bless us, even though you are busy and out somewhere in a function. So thanks a lot. Thank you.
Yeah. Bye-bye.
Bye-bye, ma'am. Now, I would like to welcome Dr. Kiranmai Devineni. She's the chairperson, Foxy Dhira Committee. So, No to Wow Committee, that is Violence Against Women Committee 2022 to 25, core member of Foxy Youth Cell, core member, coordinator, TOT and Faculty Dhira Initiative Against Women, member ISOPAB, IMS, CIMP, IMA, SFM, Stillbirth Society of India. She has received the Yuva Foxy Orator Award 2013. Foxy Dhira.
Dr. Asha ma'am. Asha ma'am. Yeah,
okay.
I think that would be.
So welcome, Dr. Kiran. Over to you for your words of guidance.
Thank you. First of all, thank you so much for this honor, I would say. I'm not senior enough to be a guest of honor, but I could not say no to you, madam. And a wonderful program. I know you as a wonderful academician. I've heard you with a keen interest in a wide variety of topics. And today's symposium or seminar is on prediction of preeclampsia and prevention aspects, both first trimester, second trimester, and then there is a panel on how to apply those guidelines to clinical case-based scenarios. And we have our friends from Warangal, Mancherial, Nalgonda, Nizamabad, Nalgonda, so many places from Telangana. And we have none other than Balamba Madam, who would be esteemed speaker. Madam is our teacher, and Dr. Manjula is our colleague and friend and Professor HOD from Hyderabad, Durgabai Deshmukh Hospital, and so many other friends are there. And I just congratulate you and best wishes for all your endeavors. And I wish you all the best. Thank you so much.
Thanks a lot. Thank you for making the effort. I know you're also out somewhere and you've just entered, I think.
No, we are in the AICOG office secretariat. So the work is going on. Thank you. Thank you. Anyway.
Thank you for being with us.
Thank you for having me. And it's a privilege and pleasure to be with you. Thank you so much.
Thank you. So now I welcome our esteemed faculty from Hyderabad, Karimnagar, Khammam, Mahbubnagar, Mancherial, Nalgonda, and Nizamabad, and Warangal. I thank you for placing your trust in me and allowing me to have this program. Thank you, Dr. Sangeeta Sujayashree, for actually facilitating everything. It was because of you that I gathered the courage to actually do this program. So thanks a lot to you. And now I would like to introduce the chairpersons, and then the chairpersons can take over to introduce the speaker. So we have Dr. Chandramati P. She's an MS Obstetric Gynae FICOG, Director of Sri Chandra Hospital, Karimnagar.
Good evening, ma'am.
Good evening,
Good evening, Asha, ma'am. Thank you so much for considering me and giving me this opportunity to chair this session. I indeed feel very honored. And thank you for including me in this prestigious webinar, ma'am. Thank you.
So, next slide, please. We have Dr. Shailaja ma'am, Shailaja B. She is Director and Clinical Head, Department of Obstetrics Gynae at Shamala Hospitals, Khammam. She was awarded FICOG in 2017. She's
Madam, thank you, ma'am. Thank you, ma'am. No need for introduction. Just put the slides and let us start the program. We are really honored to be part of this program. It's a wonderful platform to share our experiences. Thank you, ma'am.
We also have Dr. Vijayalakshmi B. MBBS from Gandhi Medical College, DGO from GMH Hyderabad,
Thank
and
you.
past secretary and present serving president of Mehboob Nagar Foxy Society. Welcome, ma'am. Now I hand over the session to the chairpersons to take it further for the first session. So I request the first chairperson to introduce the speaker and the second one to introduce the topic.
Yeah, good evening, all the delegates. I feel honored to introduce Dr. Manjula Rao, ma'am. She's a senior consultant and HOD, Durgabai Deshmukh Hospital. She's MD, FICOG, FMAS, and she is a Foxy Associate Member of RCOG, member of ISUOG. She's a treasurer for the present OGSH. She's a zonal coordinator for Gurukul Meda Foxy ICOG PG training program, and she has a lot of publications in the national journals. And her special field of interest is in high-risk pregnancy, adolescent gynecology, and endoscopy. I welcome Madam Manjula Rao, madam, to please preside over
Thank
the
you so much.
session.
Thank you. I think the admin has to allow me to share screen. Yeah. Thank you, first of all, at the outset, Dr. Asha Jain. It's indeed a privilege to be a part of this webinar, and it's wonderful to be speaking
Manjula,
alongside. Yeah.
I would like Dr. Shailaja ma'am to say a few words about the topic, and then you can please proceed.
Sure.
Madam, at the end of the talk, I would request ma'am to say a few words.
Yeah, ma'am, at the end of the topic, I think it's better to give a synapse of this.
Okay.
That will be better. Ma'am, Dr. Manjula, ma'am, please continue.
Yeah, so good evening, everyone, and respected chairpersons. My talk is on prediction for preeclampsia in the first trimester. Now, as obstetricians, we know that preeclampsia is indeed a very it's the most common medical problem we seem to be facing day in and day out, and each of us should be able to know how to tackle this situation. And now we have this screening program, which is very well validated all over the world. So if you just look at this slide, you have on the left, you have this pyramid of antenatal care where, long ago we used to probably start antenatal care around 16 weeks. And then as pregnancy advanced, the number of visits would increase because that is where we would discover all the pregnancy complications like hypertension, anemia, etc. And now the pyramid of care has totally reversed. We are now starting at 12 weeks. This is the first checkpoint where we actually triage women. We assess her risk for various medical disorders, not just preeclampsia, even for IUGR, for fetal aneuploidy screening, and for metal and so many other issues, which we actually triage a woman at 12 weeks, and then we assess her risk and then triage accordingly. So a brief introduction. Preeclampsia is a pregnancy-specific disease which affects 3 to 5% of all pregnancies, and worldwide it kills almost around 76,000 women mothers all over the world, and 500,000 babies die antenatally in the womb, during the process of death, and in the neonatal period directly as a result of these hypertensive disorders in pregnancy. So if you just look at the Indian statistics, the National Eclampsia Registry, the incidence is of preeclampsia is around 10.3%, and the incidence of eclampsia is 1.9%, out of which more than 50% cases occur antepartum. And the maternal mortality, which is attributed to eclampsia, is pretty high, 4 to 6%. So how do we classify the hypertensive disorders? It is like this. This is just to recapitulate. We have chronic hypertension, gestational hypertension, preeclampsia, and superimposed preeclampsia. This is what is given by the International Society for Study of Hypertension in Pregnancy. So we know chronic hypertension is something which predates or antedates a pregnancy, whereas a hypertension which arises de novo at or after 20 weeks is what is known as gestational hypertension. And if there is proteinuria, it becomes preeclampsia. Even without proteinuria, if she has organ dysfunction, like kidney injury, liver injury, or any of these symptoms, it becomes preeclampsia. So while proteinuria will classify hypertension into preeclampsia, it is not necessary to make a diagnosis of preeclampsia because you have, if you have other organ dysfunctions. Now, preeclampsia is also classified as the non-severe variety, where you have a blood pressure greater than 140/90, but not the severe, not up to 160/110. And she has no premonitory symptoms or normal lab values. And then you have also the severe variety of preeclampsia, where the BP is very high, or she may have premonitory symptoms or symptoms of eclampsia, or she may have abnormal lab parameters. Now, there's again a very distinct classification of preeclampsia based on what gestational age it occurs. So you have this early onset preeclampsia, which is onset of proteinuric hypertension before 34 weeks of pregnancy. And in this kind of preeclampsia, the maternal complications are more severe. The baby's complications are more higher. But the thing is, this early onset preeclampsia is less common than the late onset preeclampsia. Preterm P is whenever the baby is born before 34 weeks as a result of preeclampsia. Late onset preeclampsia is onset of proteinuric hypertension after 34 weeks of pregnancy. The maternal complications are less severe, and low birth weight and fetal growth restriction is less common, and term P is after 37 weeks. Now, this late onset PE, although the complications are less severe, the volume of the cases or the burden of the problem is mostly in this area. That is why this is a significant health burden to all of us. And we have to know that there is a distinct etiology of early onset PE, which is a placental disease, and late onset preeclampsia, which is more likely to be a metabolic disease arising in a mother because of her metabolic problems. And as I mentioned earlier, late onset PE is 7 times more common. And just a brief etiology here on the left, you have this diagram, or the placentation. This is basically to show the defective placentation. It's a placental disease. So here you have the spiral artery, which has undergone remodeling to become a large capacious vessel, where you have a low volume of blood, and which is providing oxygenation to the villi. Whereas on the right, you have the muscular wall of the artery is retained. There is no remodeling. The spiral artery is very narrow. And then you have high pressure jets of BP, which blood flow, which comes into this and damaging, including the villi. So this is the basic difference between a woman who is going to develop early onset PE and a late, this is the woman who's going to develop early onset PE, and this is a normal woman. And these are 3 stages of placentation, which are defective trophoblastic invasion, which results in a stressed placenta, which results in triggering release of endothelial dysregulation and factors. And many of the biomarkers are released as a result of which, causing the stage 3, which is a widespread endothelial dysfunction in the mother, resulting in organ damage. So why is it necessary to screen? We need to screen because now we have a preventive agent, namely aspirin and calcium in areas where they are calcium deficient. So now aspirin has proven in meta-analysis to prevent the early onset preeclampsia if it is started sufficiently early. It is also important in triaging women to different models of antenatal care, and also possibly to recruit high-risk patients to trials of novel prophylactic therapies for preeclampsia. Now, just a brief mention of what the ASPIRATE trial showed in this. Why I'm saying is that this prevention is possible. So you can only screen a disease for which there is a preventive strategy. And the ASPIRATE trial has conclusively proven that in pregnancies who are screened high risk for PE, administration of aspirin reduces the rate of early onset PE by about 90%. Prophylactic use of aspirin does not, however, reduce significantly the incidence of term preeclampsia. Okay, so how do we screen for this disease which seems to be taking so many maternal lives? There are various methods measuring the mean arterial pressure. We have a checklist of risk factors which we tick in the maternal history, and each of those risk factors gives us possibility that the mother may develop a preeclampsia. We have biomarkers which are in clinical and commercial use, which also help in predicting a preeclampsia. And we have a combination of all these factors, including the uterine artery pulsatility index. And what is new is the first trimester screening using a combination of all these factors. And screening for PE later on in pregnancy will be discussed by Balamba madam. So this is just to give you a timeline of important developments in preeclampsia screening. So starting, we were all quite familiar with the NICE guidelines, which gave us a checklist of factors to tick. And then if the woman had high risk, we could give her aspirin. If the woman had 2 moderate risk factors, we could give her aspirin. So that was in 2010. And subsequently, many models have developed. Even the ACOG came up with its checklist model. And even the US Preventative Task Force. But however, aspirin trial has conclusively shown that 150 milligrams of aspirin does prevent early onset PE. And in 2018, the FMF model became validated and it was endorsed by FIGO in 2019. So today we have a very good FMF model wherein we are able to screen for preeclampsia. And we also I have to mention here our Indian version also, the gestosis scoring, which also falls in the same category as NICE and ACOG guidelines, which has a checklist of factors which we need to tick and determine a woman's risk of preeclampsia. So this is the NICE guideline. You have the high risk factors. Even 1 or 2 moderate risk factors will deem a woman to be high risk for preeclampsia, and we were supposed to start her on aspirin. So this is the list given by ACOG where the risk factors were divided into high, moderate, low, and there were recommendations based on this whether to start aspirin or not to start aspirin. And we have our own Indian version of gestosis scoring, wherein there's a series of checklists which we are supposed to take. And then in a small study, it has shown a reasonably good positive predictive value. However, here also a score of more than 3 is supposed to be taken as an indication to start aspirin. Now, just to go back to NICE and ACOG checklists, how do they perform? They perform, see, they have a modest test performance. Its sensitivity is on, especially the NICE guideline, has only 40% sensitivity to detect preterm preeclampsia. And it doesn't even tell us whether it is preterm or term preeclampsia. And one more important thing we have to understand is all these checklists, actually, the number of women who test screen positive is huge. And when the screen positivity is huge and are putting them all on aspirin, their compliance is also limited. So NICE guideline, the only advantage is that it is a simple thing, whether it is NICE or ACOG or our own gestosis scoring. It's a very simple checklist which can be administered by any ASHA worker. You can categorize them and accordingly, but they have their limitations. They do not predict to a reasonable degree of accuracy, whether it is preterm or term. And when we have a large pool of women who are being tested positive by these screening tests, those women, the compliance to take aspirin also is very limited. That has been shown in many of the tests. Now, I would be just talking about this also, but here I wanted to just comment upon the algorithm given by FMF. It has a very high sensitivity to detect preterm preeclampsia, almost to the extent of 80%. And when you select a smaller pool of high-risk women, we are able to better counsel them, and their compliance with aspirin is much better, and you are able to definitely reduce their risk of preterm preeclampsia. This has been validated in studies. But only thing is it has a cost and it is a little difficult to administer in low risk, low resource areas. And the biggest problem with this is it is not able to predict term preeclampsia with a high degree of sensitivity. So as I mentioned, let us go back to the checklist-based screening, that is NICE, ACOG, and our own gestosis scoring. There is, because each of those risk factors were derived from retrospective epidemiological studies, and there is a limited prospective evidence. And one of the biggest problems with these risk factors have no interaction with each other. With that, I mean, for example, if you have a woman who is diabetic, she's automatically deemed high risk, even though she had had prior pregnancies which were not having preeclampsia. So basically, a good risk factor, that is a good obstetric prior history, is not able to cancel her risk of diabetes in this pregnancy. So risk factors have no interaction with each other. That is why they test, the more number of women are tested as positive for preeclampsia using the checklist method. So inability to de-escalate, this is what I mean. If a woman has a medical disorder which is placing her as high risk for PE, even though she has had prior proper normal obstetric outcomes, we are not able to de-escalate her risk, and we are putting aspirin even to her. And we are not able to predict whether it is preterm or term, what is the risk which has been in any case. Most of the tests are unable to reasonably predict or accurately determine what is the term PE risk. Now, coming to biomarkers, we have various biomarkers. The first few, that is endoglin, NEBN activin, these all increase in preterm PE because they're all anti-angiogenic, including SFLT1. And those that which would decrease in a woman who's likely to have preeclampsia are PAPE, PLGF, and placental protein 13. Now, of this, PAPE and PLGF are very widely available and commercially used, and they are also used in the Fetal Medicine Foundation algorithm. This is just the various potential sources of biomarkers, and a lot of research is going on in all these molecules even now. So just a brief statement regarding PLGF is a vascular endothelial growth factor, which is essential for angiogenesis. And these levels are decreased in a woman who is likely to develop preeclampsia. And used isolated, it does predict, but it is not as high as the combined screening method. Again, there are population variations of this placental growth factor. It is seen to be a little lower in the Chinese population, and also you need to have population specific data for all these biomarkers too. PAPE is something which we have all been using for Down syndrome screening, and this also can be used for preeclampsia screening. Is a glycoprotein product produced by the embryo and the trophoblast, and has a role in the cleavage of insulin-like growth factor, which regulates placental and fetal development. And it has a detection rate, but again, alone, it may not be able to be as effective as the one which uses all the markers. Now, SFLT1 is also clinically established, and this ratio is most useful later on in pregnancy. Now, where we are today is that we are using an algorithm wherein all these competing risks, that is all these biomarkers, the various maternal factors on history, her uterine artery PI, her mean artery, they're all fed into an algorithm, and then we come at a risk. So this is what is known as the FM Fetal Medicine Foundation model. So using a competing risk model, various combinations can be appraised in addition to maternal characteristics to identify the most practical and accurate prediction. Now, there is something called a Bayes theorem. This is what this algorithm uses. So basically here you have risk factors which cancel out each other, and also in future also, if some biomarker or risk factor comes, we can add it into this theorem without algorithm, without actually trying to invent a new algorithm. So now a few things which I just wanted to mention about mean arterial pressure. This is something which every one of us can implement in our clinical practice. It doesn't require a high resource setting, and this is the FMF recommendation how you should measure the mean arterial pressure. The woman should be sitting upright, and she should have her hands placed at the level of her heart, and her feet should not be crossing each other. And you need to have these automated machines simultaneously measuring the blood pressure on both the arms, and then you come at it, you measure twice here, 2 readings here, and you take the mean arterial pressure. This is extremely important. This is a protocol for measurement of mean arterial pressure which is given by the Fetal Medicine Foundation. It is free, and we should all paste this in our clinic when we are trying to screen for preeclampsia, so that whoever is seeing is able to follow this. Then the next other biophysical parameter is the uterine artery pulsatility index. This also is very simple in people. We all do ultrasounds and we all do Dopplers, at least our sonologists or radiologists, whoever is doing. It's a very simple thing in the first trimester. Again, there's a protocol to measure the uterine artery pulsatility index, which has to be followed, because if you do not follow the right protocol and come at the right MAP and the right PI, our algorithm will give us a wrong prediction. So this again, I don't know, this is a very simple thing wherein, the transducer has to be placed in the mid-sagittal section of the uterus, and it has to be tilted slightly side to side at the level of the internal os. And then these are all certain parameters which the ultrasoundologist has to take in mind, and maybe this also is available free on the Fetal Medicine Foundation website, and we all should keep it in our ultrasound rooms and follow this method to measure the uterine artery pulsatility index, or ask at least our sonologist to use that method of so that we don't get a wrong uterine artery PI. So then this principle of the Bayes theorem it basically, I have already mentioned this, each of the risk factors is able to cancel out each other and you get a proper risk. And this is a FMF calculator which is freely available on the net, and all of us should be able to use this calculator. It just help, you need to feed all this data, whatever it is asking, and it gives us a risk for the preeclampsia. Now, see, even if you don't do the biomarkers, still just feeding in the maternal risk factors does give us some risk, which is better than the NICE guideline, the ACOG guideline, which checklist method. So you enter all the maternal risk factors, which is asking, and you get a detection rate of 53, 45, and 34 for these preterm PE and PE at 37 weeks and term PE. Now, if you add the mean arterial pressure, the detection rates increase. And if you add the PI of the uterine artery, the detection rates further increase. And if you add MAP, uterine artery PI, the detection rates further increase. And then if you add the biomarkers, that is PAP, PLGF, is the highest detection rate. So this algorithm provides even for a low resource setting to use whatever things are available with us. If we just have maternal factors, feed those maternal factors. If we have MF and MAP, I don't think there's any excuse for us not to do the mean arterial pressure. So these two are still better. Their detection rate is still better than using the checklist of NICE ACOG. See, even NICE gives us a detection rate of only 40%, but if you use the FMF algorithm, it is giving us 53%. So this is what is a summary of how, as you keep on adding, the detection rate keeps on increasing to 90% here at the bottom. And this is basically a FIGO checklist of proposed screening and management during pregnancy, a reiteration of what I have already said. So the first trimester triple test, it is called, not the ones which we used to use for Downs. This is a FMF triple test for PE screening, wherein the woman, if she is high risk, we actually are able to counsel her that she has got a 90% possibility of developing a preterm PE, and she is able to better comply with her medication of aspirin, which has to be given 150 milligrams at bedtime, starting prior to 16 weeks. There is no point starting it later on in pregnancy. However, even if she has missed the bus at 16 weeks, you can give her aspirin up to maximum of 20 weeks. But beyond that, there's really no role for giving aspirin. So what are the clinical implications? FMF algorithm is externally validated. It is validated in multiple multiracial societies, including our population, Chinese population, everywhere. And in all these populations also, the detection rates, although maybe a little lesser as compared to the white population, still they perform better than the NICE guideline checklists or the ACOG checklists. So it is always worthwhile to use this algorithm even in our country, especially when it is freely available to all of us. And as we acquire our population data of what exactly are the levels of PLGF, maybe our accuracy of this algorithm will improve. As of now, as we stand now, FMF algorithm is superior to any other method of preeclampsia screening, and more so it is freely available. And how does our screening compare with other screening tests done for other cancers? It performs very well. The numbers needed to screen to detect one case of P is 143, and look at a mammogram. We need to do 377 mammograms to detect one breast cancer, or 870 colonoscopies to detect one colon cancer. So it is worthwhile. It is cost effective doing this preeclampsia screening. So first trimester screening is very accurate for predicting preterm PE, but not the late onset PE, which is in fact 7 times more common and responsible for most of the burden of PE related mortality and morbidity. So what FIGO says is that we need to have a public health focus on this and use the universal screening for preterm PE using the FMF test. And it endorses a pragmatic approach commensurate with resources. So if the biomarkers are not available, the algorithm doesn't compulsorily ask for the biomarkers. It gives a risk based on whatever you have available with you. So this is again a summary of what I have already said, that if using all these methods, she comes as low risk, that is less than 1 in 100 routine care, and if she comes as high risk, you give her aspirin 150 mg at night from 11 to 14.6 weeks until 36 weeks of pregnancy. So the challenges are low middle income. It may be difficult to implement the triple test, but we have the pragmatic approach where we can use whatever is available, just the maternal factor or just the mean arterial pressure or the uterine pulsatility index, or if you have the Down syndrome screening, which most of are doing a PAPE, that can be still used. And this calculator is available free of charge and we should use it. However, a rule-in test for term B remains an unmet clinical need. And accurately identifying, I would like to conclude that all of us should strive to do the risk assessment, not only for preeclampsia. I think at 12 weeks, there is a whole number of risk assessment tests which we should be using, and use whatever means that we have to categorize women who are at risk, or try to identify women who are at risk for at least the early onset preeclampsia. Thank you so much for this opportunity, and thank you for a patient listening.
Ma'am, Asha ma'am.
Chairpersons.
Dr. Asha.
Floor is yours, Dr. Shailaja and Dr. Vijay.
Yeah. Thank you, ma'am. I
And
just
Dr.
want to say a few words. Wonderful for the excellent lecture on the first trimester screen, Dr. Manjula. It was very informative. Yeah, as you said, I think most of us are doing the NT scan with the first trimester screening. Most of the information we get. Apart from that, the gastosis score can be done by a junior doctor or a senior sister who can, if we train them, they can do it. They can just mark and give us the score with which we can identify these women, and at least we can avoid, though not completely the eclampsia, early eclampsia we can. Early pre-eclampsia we can avoid with all these investigations and all. And I'm sure we can do the gastosis score and MAP, mean arterial pressure, first trimester screening with the NT scan. Most of the information we get in that. Wonderful, ma'am.
Thank you, Dr.
Yeah.
Thank you, Dr. Manjula. It was a very good presentation, Manjula.
Thank you, Vijayalakshmi. Nice to see you here. Thank you so much.
I think we should start doing mean arterial pressure with both hands. That's what we're missing. I think that's the take-home message for us today.
Yes.
And since I come from rural background, we practice. So minimum we can do is high screen FM guidelines, fetal medicine guidelines, and mean arterial pressure. That's the minimum we can do. And anyway, we are doing 12 NT scan we are doing. So if we combine it with uterine artery, it will help patients a lot. Thank you. Very nice presentation.
Thank you, Dr.
Thank you, Dr. Manjula, for the very elaborate discussion about the first trimester prediction test. Especially you have enlightened us with that FMF test, the FMF foundation, how to utilize it. So that was really wonderful. And most of the patients come at times, they miss the double marker, where PAP A is one of the component of the double marker. So if they miss that, the PAP is not there in the quadruple marker. So you have also told about this triple test, and also in case if we miss one marker, we have other options to.
The algorithm takes maternal history alone, it gives a risk. It takes the mean arterial pressure history, it gives a risk. If you feel, so basically the accuracy of your detection keeps on increasing if you use better, like you feed everything, it will give you the highest detection rate. So it is useful for all resource settings.
Yeah, maternal characters and history is very important, which we are not taking much focus on it in our busy day-to-day practice.
Thank you, Dr. Manjula. And thank you, respected chairpersons. You have really fulfilled my vision. I'm a fetal medicine specialist. I've been using the FMF score and everything for the past 5 years. I do my own scans. So what is my request to all gynecologists here and those who are listening? As a take home to this first lecture, train your staff to take the blood pressure in the correct way. That is what we can do. We are not doing it actually. When I started taking BP in both hands, patients would shout that nowhere this is done. Why you're doing it? But gradually, I had all those posters that Dr. Manjula showed in my OPD that, see, this is the correct way to do it, and that's why we are doing it. So you have to train the patients, and you can train your staff to take blood pressure twice and get the average, the mean arterial pressure. You'll get that way. Means that is not your effort on any way. It can be done. Number two is the history. If you have it in front of you, the chart of FMF, you can just ask, it's not rocket science. It's very, very basic. Dr. Manjula, I would have loved you to actually read out the points on that. But okay, we'll cover that in the panel now. So basically, it's which country of origin you come from, what is your height, weight, BMI, then what is your mean arterial pressure, what is the uterine artery PI, and what Dr. Manjula said was very important, that the PI has to be measured correctly. The cursor should be placed in the direction of the flow. If it is placed in any other direction, the values are wrong. So when you are reading the report, even if your radiologist has sent it, PI is very high, you need to see how the cursor has been kept. If the cursor is not correctly kept, then that value doesn't have any value. So, you can learn doing it. It takes hardly 2 minutes. But uterine artery PI, at least the basic blood pressure and the history of PIH, history of preterm labor, history of phospholipid syndrome, history of PIH in her parents or in a fast pregnancy. Not difficult to take. Again, if you can take the gestosis history, you can definitely take this. So it works really well. And we will be talking about the second trimester. Let us see where that takes us. But now even late PIH can be predicted. It's no more that it cannot be predicted. Yes, it can be predicted. It cannot be prevented, but it can be predicted. So let us proceed further for that. And I thank you with folded hands for doing real justice to the topic. Thank you, Dr. Manjula.
Thank you, ma'am. Thank you.
One request, Dr. Asha Jain, madam.
Yes,
Madam, one request. The faculty link is, the voice is very good, but for delegate link, they're unable to hear the voice, madam. So they're asking.
You know what? Share the faculty link. Share the faculty link.
Okay, madam.
Let us see whatever happens, because if they are not able to hear, what's the point?
Yes, ma'am. Okay, thank you.
Thank you, ma'am. So, has Dr. Madhu Chandan joined? I don't see him. He hasn't joined. Dr. Swarupa, you'll have to do the honors then. So, may I have the CVs, please? Dr. Swarupa Rani, ma'am, is a proud Hyderabadi, proud student of Osmania Medical College and Gandhi Medical College, Hyderabad, director of Swarupa Hospitals, Mancherial, founder of Mancherial Obstetric Gynec Society. She is currently the president of Mancherial Society, past secretary of Mancherial. She is an active Foxian, TOT for Dhira, RAC. Proud to share that the first time in history of Dhira training, 4 schools went online. At a time, successfully trained 1,500 students till now. She has conducted many health camps, anemia screening camps, Dhira cancer screening camps, and many CMEs and workshops. So welcome, Dr. Swarupa Rani, ma'am. Next, please. Yeah. Next, Dr. Madhu Chandan. I will introduce him. Piyush, the previous slide, please. Dr. Madhu Chandan S. is the president of Warangal Obstetric Gynec Society, retired assistant professor of Kakatiya Medical College, consultant obstetrician and gynecologist at Jivak Hospital, senior consultant and DNB coordinator at Prashanti Hospital. So welcome to the chairpersons, and please introduce the second speaker, respected Balamba ma'am.
Ma'am, there's a slight issue. Dr. Swarupa Rani has not logged in. She's missed surgery, and neither has Dr. Manu Chandar sir. So we don't have either chairperson for this session.
If any from the first session are there, ma'am, would you mind taking it up?
We can ask the same chairperson to continue the second session.
Dr. Chandramati, ma'am?
Yes, ma'am.
Would you please introduce Balamba, ma'am?
Yes, madam. In fact, I feel very honored to take great pleasure in introducing Dr. Balamba, madam. Balamba, madam is a senior
I think everyone knows me, Dr. Chandramati. Let us not waste time. Let's go ahead with the talk.
Pleasure to be see you, ma'am, in this platform.
Thank you. Thank you so much. Thank you. Yeah. Honey. I'll share my slides then. Okay? Right. Thank you, Chandramati.
Thank you.
Welcome, ma'am.
Yeah. One second. Just I'm sharing my screen. Sorry for the delay. Yeah. So I'm going to speak about screening for preeclampsia in the second trimester. Now, Manjula has done all the introduction. So why are we worried about screening in second trimester? Yes, we have done the screening for first trimester. We have given them the aspirin to prevent the complications. Now, mind you, aspirin does not prevent the incidence of preeclampsia. We all must understand that. Aspirin prevents the complications, especially the fetal complications, by not compromising the placental function. In fact, it opens up the placental vessels by allowing the clotting not to happen. That's all the aspirin does. But aspirin does not prevent the complications like abruptio placentae. Sometimes, because it opens up. Then the problem is, here the high blood pressure in the mother. The high blood pressure is the cause of all the complications. It is not only the placental functions. The placental function especially is compromised, causing fetal effects. But the maternal effects start much earlier than that because of the angiogenic factors and the anti-angiogenic factors. So what are we going to do by doing the second trimester screening? So why at TIFA screening? Because at 19 to 22 weeks, we are doing the TIFA screening. So why at TIFA screening, we are worried about screening again for preeclampsia? This is to assess the risk of preeclampsia obtained during the first trimester and to assess the prophylactic use of aspirin. You have started aspirin by 16 weeks, you have screened them, you found that there is a positive predictive value, and then there can be a preeclampsia. So it is possible to accurately identify 85% of women at risk who may develop early preeclampsia before 37th week by doing a screening even at the TIFA, not early TIFA, the late TIFA, and 45% accuracy after 37th week of pregnancy. Now, after 37th week of pregnancy, we know that the maternal complications will be reduced, the fetal complications will be reduced because the fetus has reached the maturity. And we all know now that the term starts only from 37th week of pregnancy. It is from 37th to 39 weeks, early term. 39 weeks to 40 weeks is the term. So that is what we all know about. And this has been published in Age of OG. And we know that this predictive value is very good for us. Next. And here again, what we do is, we do the pulsatility index of the uterine artery along with the maternal risk factors and maternal characteristics. And then, we can do the quadruple marker also. I'll come to it by and by, and we'll talk about it that way. What is the second point in assessing the risk of preeclampsia during second trimester? It helps in fetal growth monitoring and identifying the risk of preeclampsia before 32nd week and from 32nd to 36th week, that is a late preterm, and after 36th week. So that, we can manage and we can alert the patient. And if we are managing the patient at a center, which is very basic, you can refer them to a higher center so that the mother and the fetus both can be saved and the complications will be less. Now, mind you, we are not only talking about maternal mortality ratio. Here we are also talking about SAM, that is severe acute maternal morbidity. So we don't want that also to occur. And mind you, we also know that the neonatal deaths and the infantile deaths are much higher in our country than many other countries. Even our neighboring countries like Bangladesh and Sri Lanka score much better in these indices. So if we can do this, we will be able to reduce substantially the neonatal mortality and as well as infant mortality, and of course the SAM also. So the assessment of PE at 19 to 22 weeks can be divided into high risk, intermediate risk, low risk. So high risk will be monitoring at 24 to 13 weeks. You assess the risk for preeclampsia at 32nd week, even in intermediate risk. Then you divide again into high risk and low risk. Again, high risk, you will be monitoring more vigilantly, and low risk as usual. And of course, low risk, you go ahead and do whatever is necessary. Okay. Now, second trimester screening for preeclampsia using maternal characteristics and uterine and ophthalmic Doppler. See, it has been very fascinating to listen about the Doppler of ophthalmic artery. We all know that in hypertensive diseases, the ophthalmic artery is looked at, and we have been doing it as students, way back when we were postgraduate students. We all had to do fundoscopy in eclampsia and also in severe preeclampsia, so that we could identify which part of the which type of people will be more prone for eclampsia. Now, of course, no one does the fundoscopy for ophthalmic artery changes. Then, we used to look for the these things, the arteries, the silver wire arteries, and then what happens, the dilatation of the veins and all those things. All that, now nobody looks at. But the ophthalmic artery Doppler between 18 and 25 weeks, as well as the uterine artery Doppler, has been done by Paulo Cesar, Prasciano, D'Souza and group. And what did they find? They found that the maternal characteristics included, they included these things: the BMI, the parity, mean arterial pressure. Of course, it goes without any doubt, mean arterial pressure is very, very important. And the pulsatility index of uterine artery Doppler and ophthalmic artery Doppler. Next. Now, best results were obtained using maternal characteristics, mean arterial pressure, maternal uterine, and they also added ophthalmic Doppler, but they concluded ultimately that maternal ophthalmic artery Doppler did not promote a significant increase in the preeclampsia detection. Now, maternal ophthalmic artery Doppler, for us to learn is very difficult. It is for the radiologist to do or the ophthalmologist to do it. And naturally, we were all very excited to learn about this Doppler in the prediction of preeclampsia. But now that we know, it is not very important. It doesn't add much value to the prediction. I think, we are better off not learning about maternal ophthalmic artery Doppler. So that is what they. And then, as Manjula alluded to, the accuracy of second trimester prediction of preterm eclampsia by 3 different screening algorithms were again done: the NICE guidelines, ACOG guidelines, and the Fetal Medicine Foundation. This was a prospective study, non-interventional study in singleton pregnancies, including the second trimester TIFA, that is the uterine artery pulsatility index, at 19 to 22 weeks. Then what did they find? The factors included the maternal characteristics, medical history, mean arterial pressure, mean uterine artery Doppler pulsatility index at 19 to 22 weeks. Then what happened? The outcomes measured the incidence of preeclampsia with delivery before 34th week of pregnancy, delivery before 37th week of pregnancy, and after 36 weeks of gestation. And what did they find? They ultimately found that second trimester combined screening for preterm preeclampsia by maternal history, mean arterial pressure, and mean uterine artery Doppler pulsatility index algorithm by Fetal Medicine Foundation was superior to screening by maternal factors alone. That means whether it is a first trimester screening or second trimester screening, it is the Fetal Medicine Foundation guidelines and their algorithm, which fared better than these guidelines. So the model of screening for PE in second and third trimester of gestation, there's another recent article published in the Electronic Journal of General Medicine. This is from Ukraine. They are at war, but they are doing a lot of studies still. And then what they did was to look at the integrated use of risk factors, that is the 2019 FIGO recommendation, but they also looked at placental location. I never knew that placental location also matters when we are screening for preeclampsia. And at USG at 18 to 20 weeks of gestation, they looked at location of the placenta and also the serum cystatin C as screening tools. In addition to whatever was being done, they added this also at 19 to 22 weeks of gestation, or they did it at 18 to 20 weeks of gestation. So what did they find? The location of placenta is very, very important. The anterior and posterior walls of the uterus are supposed to get different blood supplies. The blood supply to the anterior wall is supposed to be less compared to the posterior wall of the uterus. And it is found that location of placenta on anterior wall of uterus and lateral location showed an increase in the incidence of preeclampsia. So this is a very easy factor for us to look at. Now, once you find that the placenta is placed anteriorly or laterally, be more vigilant. Be more vigilant. Call them more frequently. Record their blood pressure properly, like Manjula showed already how it should be recorded. Calculate the mean arterial pressure and be very careful to monitor them. Now, what is cystatin C? See, we have hardly heard about cystatin C. It is more used by nephrologists and urologists. This is a protein which is filtered by the kidneys, and then it is broken into small molecules, and then it is excreted. So when the glomerular endotheliosis occurs, the cystatin C levels start rising, and it is much better predictor than creatinine, because creatinine rises much later after the renal function is affected. So cystatin C measurement also they have found. And what did they find? They found that AKI remains a problem even after delivery in preeclampsia. Even after delivering, we have had number of my students calling me up, in problems where they have delivered patients with eclampsia, where there was a renal shutdown and not recovering, and where they had to go for dialysis. And if it is tubular necrosis, well and good, they do recover. But if it is a cortical necrosis, then they may require even a kidney transplant. These are all problems of acute kidney injury, which remains a problem even after delivery of the preeclampsia, delivery in cases of preeclampsia. And again, another thing which they found was age less than 20 years and greater than 30 years had more incidence of preeclampsia. So age again is a very important risk factor. And we all used to think that age more than 40 years is only important, but they have come down because their ethnicity is different. They are all East Europeans. So according to their ethnicity, and like Manjula was saying, we also have to look at our ethnicity. Our people are small-made, but they have more incidence of hypertensive disorders. They have more incidence of diabetes. So ours is a diabetes capital of the world. And Hyderabad is supposed to be the diabetic capital of the country, India. So I think, we have to be more vigilant, and we are finding more and more young people dying of heart attacks also. So and this becomes very important because hypertensive disorders of pregnancy is a marker for cardiovascular disease in the later life, that we all know. So this has to be assessed so that, we become more vigilant, and we counsel these women to be careful and to lose their weight, take less salt, and go ahead in their life so that, they can avoid all the complications of hypertensive disorders after 10 years. It is like a gestational diabetes only. So preeclampsia during the first pregnancy or second pregnancy, in a younger woman, is a screening for the cardiovascular disease in the later life. So we have to take this opportunity to guide them, to counsel them, so that, they take more care about their health, so that, they remain healthy for a longer time. Next. Now, the HDP gestosis score can be used even in the second trimester screening. Now, this is only maternal characteristics. Yes, definitely it is a maternal characteristics. But like Manjula said, it can be used by anybody. And in our Hyderabad, all the urban health centers now are using this screening method. I was the one who introduced it to them. And they're all using this for risk profiling so that, they are more vigilant, and so that, these patients can be referred to a higher center much earlier instead of being taken care of in the urban primary health centers. So they are being sent out to the tertiary care health centers. Once the risk factor is more than 3, they're all being sent off to the tertiary care centers. And that way, this is more useful, especially in the underprivileged areas, where they can just use this score, so that if the score is high, they can refer them. It is validated and it has been accepted by the Justice Society internationally, and it is being validated more and more being used. And I am very proud to say that it has been made by an Indian in our country, and this Justice score, which adds more factors rather than what the Fetal Medicine Foundation added. Now, what is delta hypertension? So that, like Dr. Asha Jain said, recording the blood pressure is very, very important. When we were students, we had a saying, see this 140/90 blood pressure, above which we call it as a hypertension, is by the American insurance companies, not by anybody else. Our women are puny. Their ethnic background is much different. And here, we used to find a woman in the first trimester, when she comes to us, thin and puny, her blood pressure can be 100/80 only. And by 20 weeks, suppose it becomes 130/80. That means her mean arterial pressure is increasing. So once the mean arterial pressure increasing, that is what is delta hypertension. It is not 140/90, but it is only 130/80, but still she can throw a conversion. This is what happens. And all of us as obstetricians have noticed this. The patient throughout her antenatal care has been all right. And when she enters labor room, her blood pressure suddenly has shot up. Here again, I would like to caution. Please do not use only pulse oximeter measurements. Do a manual measurement also. Because sometimes the pulse oximeter measurements may be different from what we measure manually. Again, I would like to caution the digital manometers, which have been used. They have to be validated regularly, and that is a caution even Fetal Medicine Foundation says. Whereas our mercury manometer, it's very good. So do it. If you can't measure the blood pressure in both arms simultaneously, because you don't have digital manometers, don't feel bad. You can measure both, if not simultaneously, one after another. And don't immediately measure the blood pressure as soon as the patient walks into your chamber or walks into the pre-checkup room, because the woman can have what is known as a white coat hypertension. So if she has a white coat hypertension, you are unnecessarily scaring her. And that is why whenever we measure the blood pressure, we always say, measure the blood pressure again after 4 hours. And that is what we do. Suppose the pre-checkup room, they say the hypertension is there, and then they come to us, we measure it again. And most of the times what happens, where they have measured 130/90, when we measure it becomes 100/70. But that doesn't mean you should give up. You have to be very, very vigilant, because this can happen with any patient. But tell her to come back, or if she stays nearby, she can come to you. If she stays a little far away, you can tell her, go to the nearest doctor, get your blood pressure measured. So measuring the hypertension is the most important thing. And why am I saying that? I am not the only one saying that. United States Public Services Task Force, which findings are published in JAMA in 2023. That is, this year they have published. They said, instead of all these risk factors and measurements and all these predictions, measuring the blood pressure properly, regularly at each antenatal visit is more predictive of hypertensive disorder of pregnancy rather than anything else. So ultimately, like Dr. Asha Jain said, we have to teach our girls to measure the hypertension properly so that, they know how to measure. And we all know in a pregnant woman, the Korotokov sounds don't disappear. So we must know when it gets muffled, and so that you can measure the diastolic blood pressure. So this publication, in the recent JAMA 2023 says measuring the blood pressure is more important rather than going
Balamba, ma'am.
Yeah.
Are you changing the slides? Because here we can only see delta hypertension.
Yeah, I'm talking about delta hypertension only. The hypertension only I'm talking. I'm talking only about hypertension, nothing else. So how to measure blood pressure is very, very important. That's all I'm saying. Next. So the multiple marker second trimester serum screening. See, in the first trimester, we said we add PIGF, that is placenta-induced growth factor also. Here again, I would like to mention, because we don't have the measurements, commonly universally available for soluble FFS like tyrosine kinase, it is actually the ratio between the FMS and the PIGF, which is more important, because anything above 40 is more predictable of preeclampsia onset, and anything more than 80, it predicts a severe preeclampsia also. Now, in 2001, there was a publication about the quadruple marker being a predictor. So here what happens? The multiple marker second trimester serum screening for preeclampsia, what they have done is maternal serum inhibin A, free serum beta HCG, unconjugated estriol, and alpha fetoprotein levels were measured. And they found that in unaffected pregnancies, the inhibin A levels go up, but it is lowered in preeclampsia. And median free beta HCG is raised in affected pregnancies. That is because the placental tissue, it is getting dislodged and getting into maternal circulation. So that the beta HCG goes up. And the median unconjugated estriol lowered in affected pregnancies because the placenta is no longer producing enough estriol. And alpha fetoprotein does not change at all, that remains same. And to conclude, the second trimester screening is very important, but it doesn't mean that it takes away any screening of the first trimester. What it tells us is that you have to be vigilant, because we are able to reduce the deaths due to postpartum hemorrhage because of more availability of blood, and we being trained in the active management of third stage of labor. But we are finding that more and more maternal deaths now are attributable to hypertensive disorders of pregnancy. So we have to be more vigilant, and the more vigilant means better antenatal care, better measurement of antenatal blood pressure measurements in all these women, counseling them, referring them to a higher center much before she becomes serious, so that, we can have a better outcome of maternal as well as fetal health, and so that the future generations will become much better. And when we prevent this, we can always counsel them, saying that this is a screening for the later cardiovascular disease in the person concerned, so that they take more care. Thank you very much.
Thank you, Balamba ma'am. Thanks a lot. And would the chairpersons like to say something? You're muted, ma'am. Chandramati ma'am, you're muted.
Thank you very much, madam. It shows how important it is. If they miss in first trimester, still in second trimester, we can again catch them by our vigilance.
It was a very informative session, Balamba ma'am, especially about the delta hypertension, what you have told, and also about the localization of the placenta on the anterior and lateral wall, and also the importance of cystasin C, which are the newer modes of detection. And it was in fact very enlightening and discussion, madam. Overall, it was it was a very enlightening one, ma'am. Thank you so much, Balamba, ma'am.
Thank you.
Thank you, ma'am. Thanks a lot. And now PLGF is available in India. It is done by various labs. The standardization in the second and third trimester is still going on, but PLGF levels can tell incipient eclampsia within 48 hours. So that is available today to us, and it's not very expensive. Even in the first trimester, if you're already second the double marker, then what does the double marker cost in your place?
2,500.
2,500 or 3,000.
Here we are getting dual marker with PLGF for 1,200 rupees. You just have to negotiate with them. If you have volume, if you as a society pressurize them, they give it to you. So we get all three in 1,200 rupees. We don't have to pay more for that. So actually your patient is paying less and you're getting more of the information, because now PLGF is very widely available. There is Redcliffe Labs, Lilac, LifeCell, and multiple more. And nowhere it is more than 1,250 rupees. Just wanted to draw your attention to this, that it can be done. You just have to, as a group, you need to negotiate. So thanks a lot for this. I hope we will live up to your expectations, and my panelists are really ready so that we can have a blast and enjoy. We will revise what we have learned today, and we will also, Piyush, you don't have to share, I'll share. So thank you. So we'll have a blast and we'll recapitulate what we learned now, and we will revise some of the treatment as well. So all panelists ready? You can all have your mics on.
Yes, ma'am. Yes, ma'am.
Yes, madam. Ready.
Yes, ma'am.
So, I want all of you to actually enjoy it, because if you enjoy it, only then you will transmit it to the audience and they'll also enjoy. So it's a beautiful day. And we are going to start this. My slides are visible?
Yeah, ma'am. Yes, ma'am.
Yes, they're visible.
So this is a case discussion which we will base on guidelines. I'm the moderator along with Dr. Sangeeta Sujeshri. Welcome, Sangeeta.
Thank you, ma'am. Thank you.
These are our panelists and our whole team who's going to share some happy knowledge today. I have been introduced, so that's it. And I would like to introduce Dr. Sujaya.
Ma'am, actually, you can skip this and proceed, ma'am. Let's go on to the panelists.
Okay, but I would really like to say something, that you have two hospitals in Palakol and Malkipuram, and I don't know how you manage two. Even one is so tough. And you conduct a lot of awareness programs for pubertal care, menstrual hygiene. So I'm honored to know that. And we have Dr. Rehana Begum, who is the present Secretary of Khammam Society and ex-Secretary of IMA Khammam. Welcome, Rehana ma'am.
Thank you, ma'am.
We have Dr. Aparna. Dr. Aparna, would you mind actually pronouncing that?
It's Aparna Vattamvar, madam.
Okay, so Dr. Aparna Vattamvar, she is MBBS DGO and all. She's treasurer for MOX from 2019 to 20, and presently the secretary of Mahbubnagar Society and our honored panelist. We have Dr. Shirisha N. She is the secretary of Warangal Society, state council member of Warangal, and has done advanced courses in infertility. I'm glad to find someone with courses on FMF also. high-risk pregnancy faculty at government training programs and has various publications. So we have Dr. Kavita Bethi. If I don't pronounce it right, please correct me, doctor. So she is working as a curricular committee member, Kakatiya Medical College, Warangal, and she's the vice president of Foxy Warangal. Dr. Lakshmi, also an assistant professor at Kakatiya Medical College, and Dr. B. Sandhyarani, who's working at Lakshmi Narsimha Hospital, Warangal. She's HOD for DNB Institute at Lakshmi Narsimha Hospital and past secretary of Warangal Society, IMS practitioner, has many publications, has conducted many conferences. So we have really distinguished panelists. I start with the basic introduction. Now, all our speakers, Dr. Manjula, Dr. Balamba, have spoken about guidelines. So I don't really think I need to talk much about this. That hypertensive disorders, it's a spectrum. Dr. Manjula showed the diagram. The National Registry in India has an incidence of 10.3%. If I remember rightly, the incidence shown earlier was less. But this is from the Indian registry and the incidence is 10%. Eclampsia is 1.9% and 50% are antepartum, 13 are postpartum. And even if eclampsia is only 1.9%, the maternal mortality is 4 to 6% because of this condition. So, what are the problems? Why we are not able to tackle this? Because there are many myths and misconceptions in pregnancy. East, west, north, south, everybody has their own ideas. There are challenges in transport. There is low socioeconomic status, lack of easy and expert antenatal care, lack of accurate prediction methods and actually applying them, scarcity of high dependency units. And then there is an unmet need in recognizing and managing HDP in low and middle income countries. What are we going to achieve in this panel? We are going to basically categorize correct definitions, identify risk factors, and design a strategy for effective prevention and preventive measures, outline necessary investigations, prevent and reduce maternal and neonatal mortality and morbidity, prevent eclampsia, and then standardize the clinical protocols. So this is one paper from which I have taken things. So I have taken the NICE guidelines, I've taken the FMF website, I've taken ACOG guidelines and the Foxy Gestosis GCPR. These are the 4 sources that we have taken. So now I would like to ask, how would you classify HDP? Any of my panelists can answer. How would you classify HDP?
Hello.
Yes, ma'am.
Hello, ma'am. This is classified as gestational hypertension and chronic hypertension. Gestational hypertension starts after 20 weeks of pregnancy without proteinuria. In chronic hypertension, it is present before 20 weeks of pregnancy. And in gestational hypertension, it may go to preeclampsia and eclampsia, ma'am. It is divided into severe, non-severe, severe, early onset and late onset.
Okay. So what is, somebody would tell me, what is superimposed preeclampsia?
So it is chronic hypertension progressing to preeclampsia is called superimposed preeclampsia.
Yes.
So Jay, you are supposed to be asking the questions.
I was waiting for someone to answer and I volunteered. Okay, I'll just...
Yeah.
So this is one of the guidelines. So my simple question, supposing I don't know anything, I want to ask you, what is the difference between hypertension and preeclampsia? What is the difference?
Initially,
Yes,
ma'am, go on.
Dr. Aparna, you may continue.
Ma'am, can you repeat the question, please?
Hypertension is arising after 20 weeks of gestation in the absence of proteinuria and without biochemical or hematological abnormalities, ma'am.
Then what is preeclampsia?
Preeclampsia is a complex medical disorder. It's a hypertension detected after 20 weeks of pregnancy, and the proteinuria is not mandatory for diagnosis of preeclampsia. And it's a new hypertension developed after 20 weeks of gestation accompanied by proteinuria or evidence of maternal acute kidney injury or liver dysfunction, neurological features or hemolysis thrombocytopenia.
That means with end organ damage, like with or without proteinuria, ma'am. End organ damage, because it is a multifactorial disease.
So basically, it is a multi-system disorder. Preeclampsia is a multi-system disorder, whereas hypertension is only hypertension. So it is hypertension plus proteinuria, specifically gestational hypertension plus new onset proteinuria, or chronic hypertension with new onset or worsening proteinuria.
Yes.
That's the definition, but still you can.
Or preeclampsia may develop or be recognized for the first time intrapartum or early postpartum also in some cases.
Yes. Agreed. Agreed. So what is severe preeclampsia?
Severe preeclampsia, it is something preeclampsia which was worsening, madam, with end organ damage.
Okay. Right. So we will be seeing signs of end organ damage. Would you describe a few of the findings?
So some may be headache, blurring of vision, vomitings, right upper quadrant pain, oliguria, decreased fetal movements, and maybe edema, maybe or may not be seen, ascites, all complications.
Pulmonary edema. Pulmonary edema and coagulation.
These are all the symptoms that you've mentioned. What about the findings? What do you get on investigation?
Yeah, elevated liver profile, low platelet count can be there. Thrombocytopenia, low platelet count, elevated liver enzymes.
So we should go for CBP with platelet count, liver function test, kidney function test, serum proteins, total proteins, and coagulation profile also. And when we see for the investigations, it may be low platelet count in CBP, proteins may be low, hypoalbuminemia, and liver function test will be altered. They may be altered bilirubin levels, AST, ALT will be elevated, LDH will be elevated. And renal function tests, definitely creatinine will be raised, serum uric acid may be raised, and there may be, if at all it is severe form, then definitely there may be coagulation disorders also.
One thing, you are a fetal medicine person, I want to ask you, would you find anything in the Dopplers?
Ma'am, definitely the Doppler will be altered, ma'am. Uterine artery Doppler will be altered, and there may be umbilical artery Doppler changes also.
We have to make a special mention of LDH too, ma'am. LDH is of paramount importance in CBP.
LDH will be more than 800.
And also serum electrolytes also important. Measure daily urine dipstick is also important.
Okay. Now, what is eclampsia?
The onset of seizures in a patient with preeclampsia, ma'am.
Okay. Okay. So she also gets
generalized convulsions in preeclampsia, ma'am.
Now here what Dr. Balamba said was very important, the delta blood pressure. Because you may not have had high BP and the woman ends up with.
Yes, ma'am.
So now what was the need of the gestosis score?
To identify risk women who will develop.
Yes.
It is to screen out the patient at the grassroots levels?
Yes, where even doctors are not available, but there are workers who can take the history. As Balamma ma'am has said that she's instituted it everywhere. Dr. Sandhya?
Yes, ma'am.
Video on. Jay, please put on your video.
Yes, ma'am, I'm available.
Yeah, but we cannot
primary
see.
centers.
So this is the
Justosis score.
Justosis score. So many things have a score of 1.
Demography.
See, everybody says that IVF pregnancy is high risk, but here what does it say?
Only 1 point is given. The score is 1.
Yes. So an IVF pregnancy doesn't automatically make it
high risk.
High risk.
High risk. And here are the high risk. In your practice, how many patients are actually hypothyroid?
A lot, madam.
Yes.
Subclinical hypothyroidism almost all like current 20%, 20-30%.
Okay. Dr. Aparna?
Ma'am.
What is the percentage in your clinic?
On hypothyroidism?
Yes.
Yes, ma'am. Same, 20 to 25%.
Okay. I cannot see Dr. Lakshmi CKM.
Madam, good evening, madam.
Okay, good evening. Can't see you. I don't know where you are.
My video is on only, madam.
Present.
Video is on.
Video is on only, madam, but unable to.
No, now we can see you, ma'am. You're visible now, yeah.
Now you are visible.
Madam.
Okay, yes, Dr. Lakshmi. Now I can see you. So, Madam Balamba, madam has dealt with this in detail. Now this is the first question. Sujya, please take this.
Yes, ma'am, sure. So the first question is, you have Mrs. XX. She's aged 37 years. It's an unbooked case. She comes for you for her first antenatal visit at 11 plus 5 weeks of gestation. You do the routine investigations and they're normal. So is the NT scan. Along with this, you've sent for her placental growth factor, which is on the lower limit. So how would you proceed in this case?
Madam, considering considering the parameters given in the question, first thing is the age. Age of the patient is 37, and next is the PIGF value, which is low, which is again an indicator for early onset PIH, madam. So based on these two factors, if her BP is normal now, then we can start her on EcoSprit 150 mg, madam. And then follow up her with Dopplers now, and also do a double marker test, and then follow up for the Dopplers in the second trimester scan also. Then follow up with the serial BP recordings, madam.
And also uterine artery Doppler.
Uterine artery Doppler was not mentioned either.
Yes.
Think that it's normal. But
we
even
need the uterine artery Doppler, which has to be specifically said.
Yes.
And see, this is basically a capitulation of what we've already heard. Nobody is mentioning blood pressure. Where is the mean arterial blood pressure? Nobody has mentioned it. Nobody has written it.
And also, history taking plays a vital role, ma'am. Here comes the picture.
But even the BP has not been taken. How are you going to start her on aspirin without taking her blood pressure?
That's what I have told. The BP has to be recorded, and then prophylactically we can start her on EcoSprit 150 mg. And then follow her up with serial BP.
Again, I would like to say that you need to put it in the FMF first trimester scorecard. Because you cannot just put her on aspirin, because if her score is high, you put her on it. That is how the compliance was more. Otherwise, the compliance will go away.
More than 3 factors.
The history, the blood pressure, the uterine artery. Once you put all that, you have a 90% prediction, right?
Yes.
So you need to put it in this calculator. You have to put it in this calculator. So you have done the NT scan, means you already have the crown rump length. It is a single pregnancy. You have the date. You have the mother's date of birth or her age, height, weight, racial origin. Does she smoke or use tobacco? If she has, her mother has had PE, any medical history, what is her obstetric history? Then the mean arterial pressure, mean uterine artery PI. These can also be just clicked here and you will get the calculation. If you click here, you can calculate it right there and the date of measurement. You have her PLGF, you put it there and you do the calculation. Please don't miss this out. Even after discussing for 1 hour, we come back and we forget blood pressure and the calculator.
Yes.
So now you've done it. So this Balamba ma'am has shown with great detail to take blood pressure in the correct way. Now the healthcare professional has to actually correctly take the blood pressure and then check all these things which are already there. Right? This is how you're going to assess the patient. Now, before I go further on this, what are you going to do? Now we had said that, you take her blood pressure, you've taken her mean pressure. Now she is high risk. Now she is high risk. She has been detected high risk for PIH. May I ask, will you start her on aspirin?
Yes.
Yes, ma'am.
Yes,
Yes,
ma'am.
ma'am. Till
Yes.
What dose?
150 milligrams at
oral
bedtime till delivery.
150 at bedtime. For how long?
Till delivery. Up to 36 weeks, ma'am.
Up to
delivery,
36 weeks. And are you going to start her on low molecular weight heparin?
No, madam.
No.
Features corrective of Apras.
Exactly. No.
No.
Now, are you going to put her on calcium?
Yes, ma'am.
Yes, madam.
We put all our women on calcium. We also
Yes.
have to correct her vitamin D levels because in our country, most of the women are low on vitamin D. Right? Without that, the calcium is not absorbed. This is what we are going to do. Now, what else have you planned for her?
We ask the patient
follow
to have
for every 15 days.
Second
ma'am.
trimester.
Would you follow her up in 15 days?
And also blood pressure monitoring, home monitoring blood pressure and frequent visits of blood pressure monitoring.
Right now, see, her mean arterial pressure is high, but her blood pressure is not high.
Not high.
Yes.
Right? Her blood pressure is not high. So what are you going to do? How are you going to follow up this case?
daily BP monitoring. And we may ask her to admit for the blood pressure monitoring. If at all she's willing, we can
Ma'am, she is
No,
11
it's
weeks,
the
5
first
days.
trimester.
No, I think what
No,
ma'am is
not
trying to
admission,
ask.
mean
no
arterial
admission.
blood pressure, I mean to say.
No, ma'am, I think what madam is trying to get at is she's trying to ask with respect to her OP visits, with respect to the proteinuria and the scan. All of them in total, how would you all proceed is what ma'am is asking.
Yeah.
See, we are talking of prediction, right? You have predicted that she is likely to get pregnancy-induced hypertension, right? So now what are you going to do? You've started her on aspirin, but how are you going to monitor her?
She will comes under high risk pregnancy case.
So,
Ask the patient frequent visits at least every 15 days and do urine protein
Creatinine.
This first trimester scan is
I'm
important.
asking you, when does it, at the earliest, when do you get PIH?
20 weeks.
At least 20 weeks of pregnancy, ma'am.
Huh?
20 weeks of pregnancy,
No,
at least.
you don't get it 20 weeks, you get it 24 weeks at the earliest.
22.
Okay, you get it 24. So what is the point of terrifying her from 11 weeks, 5 days? She can come for her monthly visits, no issues.
Yes.
Okay.
She can come for her monthly visits, but at that time she has to get proper care. When her TIFA scan is being done, what would you advise?
Uterine artery Doppler.
Correct, Doppler.
Placental position, placentation.
And
Uterine
artery notches.
notch.
See, the notch is thrown away now. The notch doesn't have any value. Okay. So you will see that the uterine artery Doppler is taken correctly and you will get the mean arterial pressure. All right. What else are you going to do? What Dopplers are you going to do?
Yeah, follow it up with the
renal artery Doppler can.
No.
Not better than.
Usually after the uterine artery, we usually
Sorry,
follow it up.
I thought for the mother.
See, at the TIFA scan, you will do the umbilical artery Doppler. You will also do the ductus venosus. You'll do the ductus venosus. You'll do the umbilical artery. You'll do the uterine artery. Now, when are you going to call this patient? Again, after the TIFA?
Again, after 1 month only.
1 month only, madam.
1 month only, ma'am.
Okay. And then after that, how frequently are you going to call her?
Every 2 weeks.
Every 15 days, 2 weeks.
Every 15 days. Are you going to give her a checklist of symptoms?
Yes, ma'am. Maternal alerts are there.
Yes.
We'll ask her to notice about persistent headache.
If you have that printed checklist,
yes,
that you
that
can
would be
hand
fine.
over to the patient, that, you know, if any of this happens, come.
Yes, ma'am.
Yes.
Headache, black of vision, vomiting, epigastric pain,
edema,
pain, and sudden excessive weight gain, and severe edema of the body, ma'am.
Okay.
And
Aliguria.
Decreased.
And can you make a mention of the urine dipstick?
Urine output also.
Here?
Yeah.
Aliguria.
Dipstick test should be done routinely, regularly.
And
So now,
for each and every visit.
Full Peyer's code can be used anytime during pregnancy. PrEP is up to 34 weeks. And the basic thing is nobody is going to predict neonatal outcome. So these are the maternal alerts. These are the maternal alerts. And Dr. Sujia mentioned LDH is really important. Now, what are the normal creatinine levels in pregnancies? Would somebody say that?
Less than 1.9. 0.9.
0.2 to 0.8.
Who answered that?
Dr. Sandhya ma'am.
Yeah, very right. So that is very important. In pregnancy, it is 0.2 to 0.6, extendable to 0.8, but no more than that. So if it is going above that, you have to be alert. So you have to advise a creatinine level. You have to be alert about LDH and uric acid as well. And these are the symptoms and these are the lab investigations. So what are the basic lab tests that you're going to do? This we've already covered.
Yes.
Now this is case number 2. Sujia, over to you again.
Yes, ma'am. So you have Mrs. XY who's aged 30 years. It's a gravida 2 para 1 living 1 who has had a previous history of preeclampsia in the previous pregnancy. She has undergone an anomaly scan, which is normal, with normal Doppler study, and the BP reading is 140/90, and the placental growth factor value is less than 100 picogram per ml. So how would you follow up this patient, and what would be your advice? How would you counsel this patient?
May I intervene a bit?
Ma'am, gestation age not mentioned.
See,
5 months.
It's an anomaly scan, no? So it is 20 weeks approximately, but it cannot be a normal Doppler. A uterine artery Doppler will have a high PI. A uterine artery PI will be a little on the higher side. It may not be very high, but it will be a little on the higher side. Now you may proceed. How are you going to follow her up and what would be your advice?
This patient comes under early onset of preeclampsia, ma'am. Here the complications, maternal fetal complications are high. So we need to follow both mother and also the fetus.
Now the FMF calculator is there. Second trimester FMF calculator. Then we have to fill all the blanks in that calculator. Because already the PLGF is less than 100, we should be like more 280 picograms per ml is normal. When the PLGF value is low. So
I think the mention should be made of proteinuria.
She's early onset PA preeclampsia or chronic hypertension.
So you have to do a proteinuria to differentiate between both of them.
BP recordings in the prior checkups.
We need some more investigations to be done for this patient.
Because,
Thorough follow-up is needed for this patient. She's already a known preeclamptic in her previous pregnancy, so she had more chance. Definitely, she may have chances of getting preeclampsia also because the placental growth factor is lesser. And the BP readings now at the 5th month of pregnancy is more 140/90. See, she's a gestational hypertension with the more risk of preeclampsia because of low PLGF factor, and she had history. So we need thorough blood investigations and the Doppler also abnormal. So she's at risk starting. So this patient should be follow up every 2 weekly, bi-weekly. And we need to give her all the checklist of
routine blood investigations.
Routine blood investigations. Probably they should be on safe normal side to be allow her to further follow up. If there are any deviations in that, then we have to treat her accordingly. And starting aspirin at this moment is a big dilemma because
we have to start.
There's no.
We have to start, madam. We have to start at anyway, 150 mg. But starting now,
as per guidelines, you cannot start, and there is no need.
Because that is
the presentation has already.
The placentation has already occurred. The second wave of placentation has also occurred by 18 weeks. So giving aspirin at this time doesn't serve any purpose. Okay, your BP is so high, and when you're giving aspirin, for some reason, if that patient bleeds, she's going to come at your throat.
Yes.
We need to start antihypertensives for this lady.
Yes. We come to that now. So we have to differentiate whether it is gestational hypertension or gestational preeclampsia. Right?
Yes.
So that is one thing. The second thing is, how are we going to manage this? What antihypertensive would you like to use?
Labetalol is the first line drug.
Okay.
Ma'am, there is a voice disturbance.
No, nothing is there, Shirisha.
No, I think it was just a slight issue. Now it's fine, ma'am. Please proceed.
Just asking you now, what? Supposing you give labetalol and her BP remains what it is, it doesn't go down. What will you do now?
But increase the
dose
dose.
are you going to give?
Dose 100 mg BD for 140/90. If it's not responding, we can increase the dose TID. 100 mg TID or 200 mg TID also, based on her blood pressure values.
And then if it is not, then we can add nifedipine also.
Okay.
No, the total maximum dose of the labetalol is completed. If not responding, then only we have to add second line drug.
Yes.
Okay. Okay.
The maximum total dose is 2400.
I'm asking you one thing. Why will she not respond? What do you have to think of more? That, why her BP is not responding? What is the differential diagnosis of a blood pressure that is not responding to labetalol?
We have to rule out other secondary causes also.
Yes. Now here somebody was talking of renal artery Doppler, right?
Yes.
Yes.
So now that is where we have come to. So this is what we've seen. The second trimester calculator, calculate. Okay. So then we go to the case number 3.
Mrs. AB, who's a 26-year-old, she's a gravida 2 abortion 1 with 34 weeks gestational age. She's been diagnosed with moderate preeclampsia at 28 weeks of gestation, and now she's at 34 weeks. So she's already on tablet labetalol, 200 milligram thrice daily, and her current BP reading is 150/100 on her antenatal checkup with you. So now what would be your treatment plan for this patient?
As she is 34 weeks, her blood pressure is 150/100. We can increase the dose. 200 mg instead of 200 mg, we can do 300 mg TID. Even if with 300 mg she's not responding, we can add calcium channel blocker, nifedipine, 20 mg BD.
Dr. Kavita, would you like to add something?
Yeah, she's on antihypertensive since 28 weeks of gestation. We'll go with investigations, ma'am, first. If the investigations or every blood investigation, everything is normal, then we can continue the pregnancy. Already she is 34 weeks and the pulmonary lung maturity will be fine. And if the blood investigation derangements are there, then I will go for antenatal steroids and then terminate the pregnancy with 34 weeks of gestation, ma'am.
No, we have to prolong.
There is a very important question of when we should terminate the pregnancy. Okay.
Yes.
So, Dr. Aparna, you want to say something? Can't hear you. We can't hear you.
Might be mute.
No, we can't hear you at all.
You can have Dr. Lakshmi add a few points, ma'am. Dr. Lakshmi.
Yeah, Dr. Lakshmi.
Madam, we can do routine hemogram and look for the platelet count. And then look for the renal parameters, protein creatinine ratio, and urinary proteins can be done.
Liver function?
LFT could also be done, and look at the AST, whether how much it has increased. Grossly, it has increased more than 3 times. Then check for these parameters every weekly, twice, 2 times a week.
See, if she now has proteinuria, if she has proteinuria, are you going to check her proteinuria again and again?
No need, madam. It is confirmed. 24 hours urine protein, if it is more than 300 milligrams, or else dipstick more than 2 plus. If it is confirmed, we don't have to check further. Only LFT and
the point I wanted that you don't have to do it every day. You don't have to do it every day. Yes, Kavita ma'am?
In this
yes, ma'am. No need to do again and again.
So,
in this case, we can prolong the pregnancy, ma'am.
How do you target when this patient is to be delivered? In a patient of PIH, how do you decide when you are going to deliver her?
In this case, we can prolong the pregnancy, madam, because not associated other comorbidities like other complications, like other signs and symptoms of imminent severe
organ damage. No.
Ma'am, I need a scan with Doppler right now at 34 weeks.
No,
Right?
I think what we assessment.
Good.
One is
the blood and investigations. LDH values.
Ma'am, what
would be your triggers to deliver her?
When you're not able to control her BP,
uncontrolled BP.
Yeah, you're not able to control her BP with adding a second line of, or if she has premonitory symptoms, or if you have deranged values moving towards help, then we have to take a call. That's what ma'am is looking for.
Yes. All that.
This is the calculator for the 3rd trimester.
Okay.
This 3rd trimester calculator will also tell you what to do next. Once it gives you a report, it tells you what to do next. So these are from the guidelines. So if your BP is 140/90 to 149/99, how much did we write?
150/100.
150/100. So that is after labetalol. You have to admit she is already on labetalol. BP has to be measured. You don't repeat proteinuria testing, and 3 times a week you'll monitor RFT and LFT and blood count. Okay. How are you going to assess the fetus?
Daily fetal kick count.
Daily fetal kick count and Doppler studies.
Now, one thing I want to ask you, if her fetal Doppler is abnormal, Will you repeat the fetal Doppler, or you would like to go on with something else?
So we'll go with NST, ma'am.
Exactly. If her Dopplers are abnormal, then the decision is not by Dopplers. The decision is by CTG.
NST.
By CTG. The CTG will decide what to do. So you are going to look at the heart and do a CTG. Okay. How do you time birth? She is now 34 weeks.
Steroid coverage is given, ma'am.
Yes.
Control
What
of
is
BP.
your opinion about magnesium sulfate?
Neuroprotective dose.
Dose.
What is the neuroprotective dose?
4 grams.
Magnesium sulfate 4 grams.
4 grams IM.
IV.
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 Okay. Now she has already crossed 34 weeks, right? So what are we going to do?
Continue maternal and fetal surveillance, and
okay,
we can prolong the pregnancy up to 37 weeks of gestation.
Do you want to cross 37 weeks? Do you want to cross 37 weeks?
No. No, for this patient, no.
As far as investigations are,
if the investigations are normal, we can wait till
BP is
37
under
weeks.
control.
No. What do you mean by investigations? Her BP is still high, right?
Yes, double antihypertensive, almost at the a full dose.
After 37 weeks, we won't continue, ma'am.
Yes. So that the take home point is that we don't want to continue beyond 37. We are happy if we've reached 37.
Yes.
So now this is another case.
It's Mrs. XYZ. She's aged 28 years. She's a primary gravida at 32 weeks of gestational age. She's a known case of severe PE on 2 antihypertensives. She's come to the casualty with seizures, and you are the attending obstetrician on duty. How would you manage this patient?
She's having
call for help immediately.
Call for help. Yes.
Staff.
And admission after counseling of the patient and attendance, we have to plan termination of pregnancy, ma'am. Before that, for termination,
Ma'am, first you have to stabilize the patient.
Yeah, stabilize the patient.
First you have to stabilize the patient before you do anything else.
Yes, airway, breathing, circulation, catheterization, and then max self doses, ma'am.
Yes.
Yes.
So what is the dose you would, what regimen would you follow, ma'am? Would it be Pritchard or Juspan?
Pritchard regimen.
Not Juspan.
Juspan regimen.
Juspan.
Juspan.
Can anyone, can anyone run through the dose? How would you administer it? What would be the loading and maintenance dose?
Like 4 grams IV, 20% as a 20% dilution, 4 grams IV slowly over 30 minutes, and followed by 5
over
grams.
45 minutes.
Do you give normal saline in such a patient?
No, ma'am. Ringer lactate, ma'am.
That is why I wanted you to read the guideline. The guideline is that you can give it because the intravascular compartment in a woman of PIH is contracted.
Yes.
So it can be given maximum ringer lactate and normal saline 2.5 liters. Okay, that is the maximum dose, and it has to be 80 ml per hour only.
Or 1 ml per kg per hour.
1 ml per kg per hour.
Okay. So this, you have to remember that we can give it. Many a time we think, no. But these are the take-home points that we have. So, you've already said that you're going to do Zuspan. Why not Pritchard regime? What is the difference between a Pritchard regime and a Zuspan regime?
One is IM and one is IV maintenance, madam. And the disadvantages, if you give IM, sometimes the toxicity, it becomes uncontrolled. So IV you can control based on urine output. Also, you can control if it's an IV regime.
And the complications of IM injection also, because it's very common complication is abscess and very painful.
Okay. So I have yet to see an overdose. I've never seen an overdose. But Yes, it is very painful. So at that time, the patient is not conscious. You can give the other whatever you want to give, but later she has a great problem lying down. So maintenance dose is given when these are the 3 points. I would like somebody to actually reiterate them.
Respiratory rate should be more than 16 per minute. Patellar reflexes should be present. Urine output should be 100 ml, at least 100 ml in last 4 hours.
We take it as 30 ml per
30
hour.
ml per hour. 30 ml per
30
hour.
ml per hour.
Because
25.
Okay. So you've given the loading dose, then you've given the maintenance dose, and convulsions are controlled. Will you opt for a normal delivery or a cesarean delivery?
based on the gestational age.
Is
He already said she's 32 weeks.
32 weeks.
That depends
Will
upon
you
the...
like to give steroid?
Yes,
ma'am.
And
yes or no? And
yes,
how many doses?
Yes,
ma'am.
Yes.
Okay. So we are going to give steroid. We may not wait for the full dose.
Yes.
Is that right?
Yes.
Rescue dose.
Okay. So we've given steroid. Now what are you going to do?
Madam, which is steroid is better?
Dexar beta.
Ma'am, we go for the assessment, madam, fetal assessment and parvaginal examination also.
Exactly. Nobody was mentioning all gynecologists. You have to do a PV.
PV examination.
So you've done a PV now.
Bishop
okay. Our Bishop score is 6. Now what will you do?
Even
on how parameters, madam, BP is controlled.
Because she's a preterm, I want to do section only, madam. Because 32 weeks is the preterm, induction and delivery very like it may cause the fetal complications like intraventricular hemorrhage and say very extreme preterm, better to do cesarean section.
Anybody wants to differ or everybody agrees? Dr. Rehana?
Ma'am, I think we need to stabilize the patient. We have to wait for 24 hours to give any anesthesia. I think the Bishop score is 6. We can wait. We can wait for up to 24 hours. Or if there are any convulsions again, then take a re-decision.
Depending upon
These
her
patients
BP.
will progress more faster than routine patients, ma'am, normal patients.
Yes. That is what. Dr. Lakshmi, you want to say something?
No, madam. Can we sometimes sometimes patient become absolutely normal, madam. So in cases we continue the pregnancy at least till we buy the steroids.
Never. No. Eclampsia, if she has had seizures, you will not wait long. Dr. Kavita?
Yes, ma'am. We can try because Bishop score is 6. We can try with induction and also with acceleration with Scinto for like continuous fetal monitoring with other blood investigations. Yeah.
Dr. Aparna? Your voice is not coming. I don't know what's happened. Sujay, you want to sum up something? What do you think? What are you going to do?
Ma'am, here, as you said, based on her Bishop score of 6, we'll have to see whether her BP is, firstly, with all this, has it come under control or she's not had another seizure when she's on her Maxil, and make a decision whether you want to give her a trial of labor, go in for an elective cesarean.
Okay. So, but you would prefer to give a trial of labor?
Yes.
With Bishop 6,
provided
yes,
the fetal condition should be good and mother should be stabilized.
Okay. Now, if she has had a magnesium overdose, then what is the antidote?
Calcium gluconate is the antidote. 10 ml calcium gluconate IV.
10%.
Okay.
10%.
10 minutes.
Respiratory support.
So, what are the reasons for which you would deliver before 37 weeks?
It's unable to control blood pressure with using 3 or more antihypertensive drugs.
So renal parameters or Doppler parameters?
Imminent symptoms, imminent eclampsia,
Or liver parameters also. Any of the worsening.
Any signs of incipient eclampsia, you have to terminate the pregnancy, right? Now, should this delivery be left to a junior sister or a junior staff?
No,
It's
no,
only
ma'am.
multidisciplinary.
Senior obstetrician should be involved in this.
Yes, because 13% will be post and 20 to 30% will be intrapartum eclampsia. We have 50% that is before, we have 13% after, and the remaining fall in the during delivery process.
Yes.
So now if a cesarean is planned, what is the anesthesia you would like to have? A spinal
General
or a
anesthesia.
general?
We
General
may go
anesthesia.
for the regional anesthesia provided all the needs to be met by anesthetist. That is platelet count should
Especially
be
the
normal.
platelet count, ma'am.
Patient should be stabilized.
Okay.
And coagulation profile should be normal.
Okay.
Especially platelet count, ma'am. If the platelet count is normal, then only they will go for they will go for regional anesthesia. Otherwise, general.
So this is another, that was the fetal medicine calculator. This is the full PAS calculator. So you can, this is also available online. You just have to click it and fill whatever you have. What is the platelet count? What is the creatinine, AST, ALT, and calculate. It tells you whether you're going to continue pregnancy or you're going to terminate the pregnancy.
Yes.
So it is an objective method of actually taking a decision where in these medical legal days you have some backup.
Evidence. Yes.
Yes. So it can be used up to 35 weeks. All right?
Yes.
This is a PrEP-S prediction model. These are the values that it takes. And then there is the placental growth factor. So placental growth factor can be done at any time in pregnancy. And combined with other tests, it tells you how soon the woman is going to go into frank eclampsia. All right. So this is a very, very important test. There are calculators for this as well. And we can work according to some objective data. If we are going to work only on subjective data, we can be questioned. You know, in our practice, there are colleagues who would probably not agree with what you're saying. Even in this panel, 3 people are saying something, 2 are saying something else. But if this happens in front of the patient, what happens? We all land in a soup. So what is the consensus? Everything should be objectified. Everything should be objectified. All decisions should be objectified. And so, if the PLGF is less than 50, you have chances of stillbirth. If it is less than 100, there is increased maternal and perinatal risk. Is that clear?
Yes, ma'am.
So we need to have at least something. Yes,
Madam, one question, Asha Jain, ma'am.
Yes,
how
ma'am.
frequently we have to do the PLGF test? How much time it will take to get the report? So
ma'am,
how
you get the report in one day. You get the report in one day. Okay. Because all blood samples are couriered by flight only and you get the report online.
And how frequently we have to do this test, PLGF
The thing is, we have talked about all the other assessments. So we do all the assessments, and whenever we feel that now we need more help, we can go for the PLGF. It can be done every week. It can be done every 2 weeks.
Yes.
Okay. Because if you have a PLGF value of less than 50, your baby will be dead in 48 hours. So you need to take it out immediately. If it is less than 100, your baby might survive for another 4 days. You get my point? So we need something objective. We need to put it Put everything in the FMF calculator or in this calculator. So the availability of PLGF tests results substantially reduce the time of clinical confirmation of preeclampsia. Wherever it was implemented, there was lower incidence of maternal adverse outcome consistent with adoption of targeted enhanced surveillance. That means better outcome for the mother and better outcome for the baby. And so also better outcome for us obstetricians.
Yes, ma'am. Yes, ma'am.
Because otherwise we are all in a soup.
Yes,
so I think I want one take-home message from every panelist before we close.
Yes,
we are really done on time. So on my screen, I can see Dr. Kavita first. So would you go ahead, ma'am? One take-home point from your side.
So in our developing countries, in low resource setting population, gestosis score must be done by each and every doctor, including, and we should train the our staff, madam, to calculate the score. And in like in a setting like in cities, we can order for NT scan. During that time, we can have a Doppler of uterine artery, if possible, PLGF, ma'am. The thing I wanted to, because I work in a government medical college. So we are asking our PGs to write the gestosis score on the OP sheet itself. And also you are having the scans. So we are writing uterine artery Doppler. But PLGF is not available in our this thing. And must implement MAP. But now and then, because the 300 to 400 OP, we may not calculate the MAP. But from tomorrow onwards,
there is no option. You have to do it.
Yes,
Dr. Ashley, you want to add something?
Madam, and start putting on the FMF, using FMF charts, madam. Make use of FMF charts.
And calculators.
In each trimester, calculators in each trimester.
Thank you, ma'am.
Sandhya
ma'am?
Yes, madam. At booking visit only, we have to categorize them into whether they will come under low risk or high risk, or they will develop future preeclampsia or eclampsia. And I made a chart like gestosis score is in our OPD room, and also at blood pressure vital chart maintenance at a vital chart area also one HDP gestosis score is there. So, and we will check blood pressure with machine, NIBP machine. So it will give the mean arterial, automatically it will come mean arterial pressure in that. So we will take consideration mean arterial pressure and gestosis score, and based on other factors, it's the best. We can prevent, at least we can start ecospring, we can prevent so many complications. It's a good idea. It's a good session also, madam. Thank you for this giving opportunity.
Ma'am, would you like to say something? One point from your side, Dr. Rehana.
Yes, ma'am. Aspirin has a role starting at 12th week of pregnancy, and placental growth factor in the 3rd trimester for the fetal risk, and scoring of the patient from the 1st trimester, previous history of eclampsia, and prediction of eclampsia, and identifying the patient is very, very important in our setup. And definitely we all should implement all these mean arterial pressure, uterine artery pulsatility, next placental growth factor and gestosis score in our OPs, and let us all identify PIH patients beforehand only, so that we can reduce the maternal mortality and also the perinatal mortality.
Thank you,
Ma'am,
ma'am.
Asha ma'am, I had two questions for you.
Yes, ma'am.
Excuse me, ma'am. Asha ma'am.
Yes,
I had two questions.
Lakshmi ma'am, you are still there.
Yeah. It's very interesting session, ma'am. Couldn't go. Madam, one thing is, once we start labetalol, how many days do I wait before I accelerate the dose?
Ma'am, you have to calculate as per the half-life. So 3 days is enough.
Okay, thank you so much. One more question, madam. Role of calcium, when do we start? How much? Till how long?
Ma'am, actually in our population,
2 grams.
The requirement per day in pregnancy, if you have a normal calcium level, is 1 gram. And if you are deficit, it is 1300 milligram. And If vitamin D levels are low, then this calcium that you're giving is not utilized. So usually we start calcium supplementation after the NT scan.
Madam, role of
Along with
antioxidants.
vitamin D.
Role
Thank
of
you, ma'am.
antioxidants, madam. Micronutrients, antioxidants.
A good balanced diet is what I would prefer over any medicine, because there is no proof for anything else.
Giving magnesium tablets.
Ma'am,
Pre-cam or
magnesium is required for absorption of vitamin D, and vitamin D is required for absorption of calcium. So most of the calcium tablets that you give will have magnesium, and if the woman is still reporting cramps, then you can add magnesium. So, Dr. Aparna, is your audio better now? No, it's not better. I don't know what has happened to it. Have you put on earphones by any chance? Remove the earphones. Remove the earphones. Dr. Shirisha, last word from you before we go to Sujaya.
Yes, ma'am. I want to insist on two things. First is proper history taking, ma'am. I insist on that. And the second one is absolute blood pressure measurement as per protocol and calculating the mean arterial pressure. I insist on these two for diagnosis and management.
Very correct and very, very important. Means only those two things can cover up to 70% of prediction. Sujaya, you want to add something? 1 point from you before Madam is here, so I will also invite Vijayalakshmi ma'am to say something. And Manjula is also here, so Dr. Manjula can also speak. Sujaya? You're muted, you're muted.
Ma'am, the take-home message for me would be that the placental growth factor can be used to help us in the management as to, how long you can prolong pregnancy or when to terminate. For me, that was an eye-opener, actually.
Okay.
And also, madam, madam, one thing, even we are doing glycosylated fibronectin levels also. That is also indicator whether it is a mild, moderate, severe, when to
terminate. That would be for HELP syndrome. That would be for HELP syndrome, ma'am.
Ma'am.
Yeah.
And
what
the doctor is talking about is that lumella, no? Isn't it?
Lumella, yeah.
Lumella.
Dr. Manjula, that is a lumella glycosylated fibronectin levels.
Yeah. Lumella test.
But somehow there is not, I couldn't find much literature validating that, so I lost interest
Actually,
in that.
when they had started that, they had given me the machine and they said, you do it and it works. It didn't really work for me, so I don't know.
Exactly.
I don't know. So, and Vijayalakshmi ma'am, would you like to say something? You've been here. I'm really honored to have both you and Dr. Manjula here.
Madam, first I'd like to thank you, ma'am, for hosting such a good and informative program, madam. It is very good. Take-home point for me was, madam, the correct posture of recording hypertension, recording of BP. So that will help a lot, I think, in our way forward in predicting any preeclampsia in future.
Thank you, ma'am.
Thank you so much, ma'am, for making me a part of this. Thank you so much.
Thank you. Dr. Manjula?
My take-home message is still, I think we should all go into that algorithm. Although I understand there are, at least for first trimester, I'm not talking about second trimester, because that first trimester, it's a free calculator and you feed the history, whatever you're taking into that. Just the history also, it will give you a risk, which is superior to any other checklist. So, and that is freely available. You just have to go to the FMF website and just, there are many calculators. One of them is this first trimester calculator.
I think we should put up in our OPs.
Yeah.
We should display it in our OPs.
On your smartphone, you can do it with your smartphone. You can access the calculator on your smartphone.
Ma'am, I will be going for this committee and I request nomination and voting from all your societies. So
all the best, madam.
Best wishes, Dr. Asha.
So I will be going for Food, Drug and Medical Surgical Equipment Committee. I seek your blessings and thank you. Thanks a lot. Yeah.
Ma'am,
Thank you,
one doubt.
I'm really honored.
Ma'am, one doubt, ma'am.
Yeah. Yes.
All the best for your for food committee, ma'am. And I want shall we start aspirin 150 mg only with Gestosis score and MAP, madam, or do we
Ma'am, go to the what Dr. Manjula is telling you over and over again. Go to the FMF. If it says it is high risk, please start. And one thing that nobody brought up that I want to tell you is why aspirin 150 when the actual dose is only 75. Why are we giving 150?
75 milligrams.
The dose
The
is
absorption
75. We
is
are giving 150. Why?
Absorption of the drug is less with the 75.
No, ma'am. It's not
up to the mark.
No, ma'am. That is not the correct answer. I want everyone to remember the correct answer, and that is up to 40% women have a resistance towards aspirin. And when you go double the dose, then that resistance is overcome. And therefore, when you give 150 milligram, then the resistance is overcome and you find the positive effects.
Okay.
Okay, because when you go to Western trials, they will tell you 80 milligram, 75 milligram, 81 milligram, 100 milligram.
Yes,
and you're worried what happens. But FMF has done a worldwide study on millions of women. And what they found was that this resistance is taken care of by 150 milligram dose. And that is why they give it on a full stomach at night so that no GI disturbance is created.
And one more doubt, madam. In like a previous history of bad obstetric history, previous history of eclampsia and recurrent pregnancy loss, why we have to wait till 12 weeks? Can we give from first trimester preconceptionally also?
Listen, the first thing is you have to rule out antiphospholipid syndrome. If it is not there, there is no advantage of giving aspirin. What does your aspirin actually do?
It increases the thromboxane, prostacyclin thromboxane ratio and increases the vasodilators.
No, ma'am. What is it is actually doing is that the spiral arterioles which are invading into the placenta and whose muscle is being destroyed so that there is a low resistance flow. That should occur, right? That should occur, and that occurs only after 12 weeks. Why are you giving it before? First trimester, the lady is already vomiting. She's in trouble. Why do you want to give it? It has no added advantage. It is good enough if you are able to give it after correct diagnosis at 12 weeks.
Okay.
Right?
Okay, ma'am.
It has been really lovely interacting with all of you.
Thank you, ma'am.
Thank you, Asha.
I've really enjoyed myself. I hope you have also enjoyed.
Yes, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you
being a part
Thank
of
you, and
this.
good night, all of you.
Yeah.
Good
All the
night.
best, madam.
Thank you. So I thank our chief guest of honor, chairpersons, our speakers, Dr. Manjula, Dr. Balamba, and all my respected panelists and my co-moderator Sujayshri for being here with us. I also thank Corona Remedies, Piyush and Mehul for making this program possible. Thanks a lot.
Thank you so much.
Thank you.
Thank
Good
you,
night. We meet again sometime.
Thank you, ma'am.
Good night.
Thank you.
Good night.
Piyush, you may end the session.